Good afternoon. Thank you for joining us today. My name is Holly Bell. I'm the Equity and Advocacy Specialist for the Utah State Board of Education. And today we're going to be talking about concussions in schools. I'm the Section 504 Specialist for USBE, and as a counselor, as educators, I was a counselor. I saw a lot of concussions come into schools, and I know it's difficult to know how to help these students to come back into school and provide them the services that they need. And I have with me Dr. Colby Hansen from the University of Utah, and he's a specialist. So for those of you who are watching from YouTube and want to receive credit, if you did not sign up in Midas, I'm asking you to type in your name and cactus number in the YouTube feed. If you're not comfortable doing that, please email Tina Morandy, TINA.MORANDY at schools.utah.gov, and she can give you credit. You can receive credit from watching online. After today, anyone who wants to access the presentation can access this from the same YouTube link, and it will be permanently embedded in there. So I'm going to give the time to Dr. Hansen. I will be monitoring questions, so as they come through the live feed, I will make sure that I ask those questions for Dr. Hansen and encourage you to participate and tell us about the things that you're experiencing in your schools, and since he's an expert, he can help us answer those questions. All right. Super.
Great. Thanks for the opportunity to chat with you guys and to do this webinar. Like Holly said, I'm a physician at the University of Utah in the Division of Physical Medicine and Rehabilitation. One of the things that I do is run our concussion clinic through the University of Utah, as well as support our programs at Primary Children's Hospital. So I am going to attempt to hopefully make this somewhat interactive on my front through a few questions on this poll everywhere process. So there are two ways you can join our session. Either if you're on a computer, go to that website and enter in Colby Hansen, or if you're via your phone, you'll text to the number 37607 Colby Hansen in the message. So I'm going to just ask you to take a moment and identify yourselves as either a teacher or perhaps a special education teacher, administrator, counselor, or school nurse, or perhaps some other role. We'll give you a minute to do that.
We have 24 on right now.
Give this just a little bit here and see if a few of you can join our polling session. Okay.
Kim says D. So
okay.
3 counselors.
Fair enough. All right. So looks like so far mostly a mix of administrators and counselors.
There's another counselor, or administrator. Anna Curry says D.
I'm saying they haven't opened a poll yet on mine.
Hi, Kim.
You might have texted the wrong thing.
Well, and if you move forward, they can
Yeah.
tell me their roles as well as
Yeah.
we go along.
Okay, so that's great. Let me just give you a brief overview here of what I hope to accomplish today. From my perspective as a physician and seeing a lot of these kids come into my clinic and talking with them and their parents about reintegrating into school, it is not uncommon for frustrations to be shared and for a variety of reasons. So first I want to hopefully impress is that traumatic brain injury represents a wide spectrum of injury and subsequent problems, and concussion is part of that spectrum. Secondly, I hope to discuss the variety of symptoms that kids may deal with after a concussion, and then briefly go into some general principles regarding recovery from a concussion, how we try to support and enhance recovery, and then jump into specifically some school-related issues, how understanding the role that the school plays in supporting a child through their recovery process, and then lastly, recognizing some of the accommodations or strategies that could be used to support the child through their recovery and some of the principles behind them. So, regarding the spectrum of traumatic brain injury severity, I'm going to ask a question here. What percent of concussions do you feel are better by 2 weeks from the injury? 25, 50, 75, or 90%? Let's see here. Oh. Did not mean to lock that, sorry.
Kim says 8.
I see.
I
I
don't have to call you out
Yeah.
on your names. Someone said A.
I see that I'm getting results for some reason they're not displaying on my screen, but that's okay. We're up to a handful of responses here.
A.
Okay, so about a third of you feel like 25% are better by 2 weeks. Most feel like half of concussions should be better by about 2 weeks. All right, so the number, somewhere between 50 and 70%. And let me just kind of go over this table. I don't mean for you to have to memorize this table, but it mainly is just to help you appreciate the spectrum of traumatic brain injury from mild to severe. And it's very much an imperfect science. We try to grade these injuries on certain key characteristics like loss of consciousness, and if there was loss of consciousness, for how long. There's a score that we use called the Glasgow Coma Scale, which is particularly more relevant for more severe injuries. Post-traumatic amnesia is another variable that we use to try to gauge or classify injuries from that mild to severe spectrum. And then there's this in-between group of kids who present with mild injuries, at least by these criteria, but some of which may have problems on a scan. And so we kind of lump them into this unique group called complicated mild brain injuries. And there are surprisingly a lot of those running around, and that may be coming back to school. And there's going to be sort of a general pattern of recovery. In general, again, about half of injuries are recovered by about a week. And you can see there's sort of a steep slope early on where many injuries get better spontaneously on their own without too much trouble. But then as we prolong the time out, that pace of recovery tends to slow down. So by about 2 weeks, we're looking at maybe 70% or so are better, 3 weeks, 80 to 90%, and so on and so forth. Now, there are, different data sets may suggest slightly different timelines. This was another data set sort of showing a similar type of graph. And they suggested that at 3 months, 12% still of these were kids, still remained with some sort of problem or symptom, and a very small percent, but not zero, at a year dealt with some difficulties. So you might ask, well, how good are we as healthcare providers at predicting those who are slow to recover? And I will say that we are not great at doing so. This picture here is meant to represent a multivariate risk model that was created from a large cohort of kids presenting to the emergency room with concussion, and they looked at several variables to try to come up with a risk score, and then they validated that against another cohort. And the picture here is meant to sort of illustrate its sensitivity and specificity at successfully predicting those who are slow to recover. And the risk model gives a score of 0.70, which is slightly better than if we just ask doctors to guess on their own. But if you look at those reference standards, it's just kind of a fair test. It's not a great test, or not a great predictive model. So some of those variables, though, were things like age. Older age, higher risk of being slow to recover within this pediatric cohort, 5 to 18 years old. Girls more than boys. If they'd had a prior concussion, if they had a prior history of headache problems or migraine, if they appear to be answering questions more slowly on that initial evaluation, or if they performed rather poorly on a balance test, presented with headache, endorsed noise sensitivity or fatigue. So the presence of those variables all earned you points on this scale, and then you can see sort of the risk stratification from low, medium to high based on those, how many points you got. Now, the Center for Disease Control recently came out with some guidelines about, it was really a comprehensive review of pediatric mild brain injury, and what were some of the factors, or what evidence is there to point to certain factors causing a risk of delayed recovery. Okay, and again, a whole host of variables have been looked at. The evidence for some of these is not great, but I just want to give you just a general sense that there's quite a wide spectrum for these injuries, and the recovery pattern can vary quite a lot in terms of the timelines that kids are looking at. And so why does this matter to you? Hopefully so that we treat each individual as an individual and not make assumptions about so-and-so's recovery taking a longer time than maybe what you assume that it should be. Now, when we talk about the types of symptoms that people deal with, they sort of tend to fall within these 4 general clusters of symptoms. And there may be certainly overlap in these symptoms. There may be more than one cluster present in any given individual. So if we just kind of talk through these briefly, the cognitive cluster encompasses things like feeling slow processing information, not being able to pay attention well, having a hard time with memory. The sleep/fatigue cluster gets it not just sleep disorder, which is quite common after a brain injury, but just that kind of daytime fatigue or mental fatigue that people often experience. The emotional neuropsychiatric cluster encompasses things like anxiety or sadness, or simply just a heightened emotional lability. And then over to the physical/migraine cluster, this encompasses things like presence of headache or dizziness or light sensitivity or noise sensitivity, perhaps some visual disturbance. And so when we are assessing kids in clinic, this is meant to just give you an idea of how we try to track that. So there are symptom scales that are validated for use in mild brain injury, created for this very purpose, to try to get at, how severe are these symptoms and what types of symptom clusters are they dealing with. And in this particular example, you can see how, as we track this, it's one measure for us to try to get a gauge on their recovery. So the total symptom scores on the bottom row there, you can see they presented on the far right column with a symptom score of 85. Many of those symptoms are in the moderate to severe range. These go on a 0 to 6 scale. And then there's some progressive improvements over the course of, in this case, it looks like about 3 months or so, but still not totally gone. So making a diagnosis of concussion is, you would think, should be fairly obvious, but it's not always the case. And I just wanted to throw this out there as one illustration of that. So even when we instrument football players' helmets with accelerometers and things to measure the magnitude of impacts, many concussions that clinically presented themselves had no discrete event identified with these instruments. And furthermore, many of them had a delayed onset of symptoms. And so it is kind of tricky sometimes, and it does merit some monitoring or education of kids and parents after maybe a hard fall, to be on the lookout for symptoms perhaps to develop over the course of usually a day or two. So again, what's your bottom line? The symptoms after a concussion can be quite variable, and they can have a variable time of presentation. Again, I hope that the message that gets across for school personnel is that, again, to treat each individual as an individual. So some of the principles of recovery. Some of you may have come across this if you've managed concussions in sports, this phrase, when in doubt, sit 'em out. And that I think is certainly good advice for in the sport context. If you're not sure, just sit 'em out, make sure they're evaluated by an appropriate health care provider. So let me propose this question for you. The best advice for a person who sustained a concussion 3 weeks ago and is still not feeling well is which of these options?
Well, the poll is locked according to one of our, so I wasn't sure if you were going to use it again, but I was told the poll is locked.
Yeah, it locks prior questions, so this should be.
So this should work.
Yeah, it looks like it's open now.
Yeah,
Perfect.
I have one result here.
Oh, good, it's unlocked.
Anyways, so continue to rest until your symptoms go away, or just go back to your usual stuff and it's all in your head. Take some melatonin, come back and see me in a couple of weeks. Go see a psychologist, or learn how to pace yourself. Try to be active, including exercise and some work or school activities. You can keep answering. I'm going to advance by one to show some of the responses as they're coming in.
No one has come through here yet. We've got an A.
Yeah. So we have either a sense of continue to rest or learn how to pace yourself, try to be active, including exercise and some school or work activities. I would make the argument that the right answer is to learn how to pace yourself, try to be active, try to stay engaged with some exercise, some school and work activities. Rest is a tricky thing. There is probably some value to rest in the immediate short term. Perhaps a couple of days, perhaps a few days. But then really it becomes a matter of balancing rest with activity. And that is so key, because the message, I think, one of the messages that has really been hit hard with concussion in sports is do not go back to play until you are fully recovered. The first step in the return to play process is often described as rest until symptoms go away. And that, I think, has sent a confusing message to healthcare providers and to parents and to coaches that we just need to keep resting, and that's not always productive, particularly if things are not spontaneously getting better. So we'll talk through some of that some more, and then jump into return to learn and play, but really this whole idea of rest and versus activity, it is a balancing act. There's a give and a take between these two ideas, and so we used to say very early on, it's important to rest, both physically and cognitively. It is important to educate children and educate families on what the natural history of this tends to be. While there is certainly a lot of variability, the general trend should be one of improvement. But instead of talking so much about rest, I tend to substitute that word with pace. And I think that gets at the idea of balancing rest and activity better than simply telling people to rest and wait it out. So it is appropriate to gradually reintroduce activities as symptoms start to abate. When we are evaluating people in clinic and considering what types of interventions we might recommend, usually things that go after sleep management and headache management early on tend to be the highest yield targets for us. It's also important to recognize that there might be other types of injuries. A common example would be a neck strain or a whiplash type of injury, and so addressing that with the right balance of exercise or even physical therapy can do a lot to helping recovery. And then talking about exercise and doing it at the right time. Now, exercise at the right time is kind of interesting. That's a moving target for us as healthcare providers. It used to be talked about that exercise should wait until symptoms are gone, and then people pretty quickly realize that that's not always very productive. So people started to investigate the idea of some low-impact aerobic exercise after injury, and introducing that maybe at 3 weeks post-injury. And what you see here on the screen is a very recent article published just this month looking at very early introduction of aerobic exercise. These are in sport-related injuries, and the net result of it was that introducing some early symptom-limited aerobic exercise, even within a couple of days post-injury, tended to yield faster recovery times than the control group, which in this case was just a stretching routine. Now, when we talk about subthreshold aerobic exercise, there's a couple important points here. So Sub-threshold aerobic exercise means there is often a point at which an individual will experience exacerbated symptoms with exercise. So you put them on a treadmill, start them out easy, nice and slow, they do okay, you progressively increase the pace or the level of exertion, and they'll tend to hit a threshold at some point where it actually worsens their headache. And so what we're trying to do is educate these individuals on where that threshold is, help them recognize when that occurs, and then encourage them to exercise at just a notch below that amount. So it might be a target heart rate amount, it might be a duration amount, but some amount of exercise below where that threshold is, and encourage them to exercise at that amount every day. And of course, this should not be confused with returning to play. Okay, we're not saying that we should return to play, return to sport, return to competition soon, but returning to exercise should be encouraged within that general concept of symptom thresholds. So again, what's your bottom line? Balancing rest versus activity is really key here, and encouraging this mindset of pacing one's activities is so important in the classroom. And returning to exercise does not mean return to sport. So what is the school's role in all of this? It may be multiple types of roles. You may find yourself in the position of a first responder dealing with an injury right when it occurs. You may play the role of providing feedback to the family on the child's recovery. That type of feedback, when I can get it in the clinic, is extremely valuable. When the parent can say, yeah, the teacher has told me that child is doing really well, or is tolerating only a certain amount of activity before they start to get tired or act irritable. That type of feedback can be really important to a family. And certainly then I think you play a role in the return to play process, and things that you do in the classroom can facilitate or unfortunately sometimes hinder recovery. So we'll talk through some of these. As it relates to return to play, which is what a lot of people care about, what a lot of people wonder about, when can my kid go back to play? And I would answer this, the very simple answer is when they are completely recovered. Well, how do we measure that? There's a lot of different things you can try to assess to make that judgment. And with all the tests that we have, it's still not perfect. There's no perfect test out there, but looking at their symptom burden, looking at how they tolerate exercise, looking at how they perform on certain tests, like a balance test or perhaps a cognitive test. Those things help. I would tend to argue that really the first two there, reported symptom burden and school performance, are probably the most insightful than tests that we do in clinic even. There are these consensus statements that come out every few years regarding concussion in sport. The most recent of which was here in 2016 by this group that met in Berlin, and they basically reinforced the same type of return to play protocol that has been talked about for probably the last 10 years or so, where you progress people through an increasing amount of activity at each stage, from introducing aerobic activity and then sport-specific training drills, and then high-intensity non-contact drills, finally contact in a practice situation, and then finally play. I don't really mean to go into this too much, but just to sort of provide that framework. This group did lay out a few pointers or a few concepts specifically relating to children. They emphasize that the same general concept of gradually increasing their activity before returning to play, that at least 24 hours should pass between stages, but in a pediatric population, it might be appropriate to prolong that, but without any definitive recommendations to do so. They did recognize the pediatric population as a unique group, and so treating them perhaps more conservatively may be appropriate. It was nice to see in their recommendations finally an acknowledgement that they should not return to sport until they have successfully returned to school. And so this is where you come into play, I think, is really important. Again, providing that feedback to those who are trying to make these decisions about, well, when is it okay for Johnny to go back and play soccer?
So as a counselor, and I'd have students with concussions that were wanting to return to the sport, or the parent would want them to return to the sport, but I knew that they were not fully integrated back into school. How do you respond to that?
That's a $1 million question. I think that I would hope that a counselor would speak up, first and foremost. Take the concern.
It's not very popular when you do, I will tell you that.
I'm sure it's not. I'm sure it's not. But you have every right, I would argue I don't know if I would say obligation, but you have every right, I think, to speak up first to the family, first to the kid, and if you're not getting anywhere, expressing those concerns to the coach, or if you have a line to their healthcare provider, which that is one of the biggest challenges that we face.
Right.
From my perspective is communication to the school, because it's all going through the kid or the family as the intermediary. But speak up in some way.
Okay.
And involve the school nurse.
And involve the school nurse.
And involve
Betty
the school
Sue,
nurse.
our senior consultant, is here. If you have any questions from a school nurse perspective, she is here, so please feel free to ask.
So again, as an educator, you may be wearing different hats at different points in time as it relates to concussion care in children, but get involved. If you're seeing things that are concerning to you, make your voice heard, and returning to learn is every bit as important, if not more so, than when they can return to their sport. So how can we facilitate recovery in the classroom? What are some of the things or strategies that could be useful to support that? So I'll just speak in a few general terms here at first. Again, the return to learn is what this is often termed, that little catchphrase. The same general principle of gradually increasing a load back into the school setting, just as we gradually increase someone's physical exertion before returning them to sport, I think that general concept is still appropriate and valid. It's important to recognize that those with patients with concussion often experience worsened symptoms with mental exertion or environments that are highly stimulating. And so balancing the right pace of resuming work is really key to helping manage symptoms and providing a successful outcome. There are a couple of examples or frameworks that are published in the literature about what this should look like, and I just have these up here as an example for you, but again, you can kind of see it's the same general concept of starting light, gradually adding things on top of it, and as they show that they can do fine at one level, adding in more responsibilities as you progress back towards full-time return to academic work and activities. Here's another example. They've broken it out into a couple of extra stages from the previous one. I think in concept these are okay. but it is really, in my estimation, being flexible, being adaptable to a given circumstance is really key. There's not necessarily any obligatory time frame that this needs to happen in, because again, those recovery timelines tend to be quite variable. For a kid who is feeling fine 2 days after the injury, they don't need to take 2 weeks to gradually work back into school. But certainly educating them about things maybe to be on the lookout for, or you being aware of things to be on the lookout for, are helpful. From the physician standpoint, this is where I sometimes feel a little bit helpless. I can't mandate to schools what to do. I can provide recommendations, and I recognize that there are different layers of support that might be implemented within the school system, including 504 plans and IEPs. I know from just my clinic experience that schools tend not to like to go to that level of 504 plans. I assume because of added paperwork or administrative things that might entail.
Well, it can actually be a temporary impairment. It's hard to know, because usually we're looking at a temporary impairment of an impairment that would last more than 6 months. So that is difficult with concussions, and sometimes they'll provide the accommodations without putting in a plan. Paperwork is really not that difficult. It's just not knowing how temporary the impairment is. But that first point is a common misconception. A lot of educators, I believe, think that the physician's rule, that is law, that whatever they say needs to happen in the schools, and don't understand. And I'm coming from 504, understanding of 504, that that's information, but not a mandate. And so I think there's a lot of misconceptions there. So I'm glad that you confirmed that that's the case.
It is certainly valuable from my perspective to try to educate patients and parents, and then hopefully they can secondarily educate their teachers of certain things to be on the lookout for. Problems, paying attention, concentrating, learning new information, taking longer amounts of time to complete a task or an assignment, being on the lookout for emotional lability, irritability, not being as adaptable to cope with stressful environments or situations, recognizing that symptoms such as headache or fatigue or light sensitivity may worsen when doing schoolwork. So that just baseline education of kids and parents is really important. And then again, from my perspective, trying to empower parents to advocate for their child by providing a letter or some other form of written down recommendations of possible academic accommodations, or even simply validating the health care provider's impression that yes, this is a traumatic brain injury. And then encouraging parents to meet with the school to discuss options, and then really encouraging them to remember that being flexible with the plan is really key. What I may say on a set of recommendations shouldn't be necessarily just something that's set in stone. A kid's classroom environment may suggest that maybe a different strategy to deal with headache, for example, might be more appropriate. So there are a number of potential school accommodations which you can take a look at here, and some of the rationale for doing so. Maybe just highlight a couple of things. Rest periods during the school day, the second one down. The rationale behind that is that, when symptoms flare, a brief period of rest may be all that is needed to allow that headache or whatever the symptom might be to calm down and allow them to return to class. rather than going to the extreme of saying, well, then you just shouldn't be in school at all. Extending testing time. The rationale for that is that processing speed and in quickly processing information may be impaired. Not that they can't do things, they just need some more time to do things. So you can take a look through some of these accommodations and the rationale for them. And certainly we can talk if there's any questions on some specific accommodations or maybe things that you've experienced or even things that you've seen work well. You know, that's a good discussion to have. Here's maybe a little bit different way of showing the same information. This table is representing the symptom that somebody might be experiencing. For example, the first one, attention or concentration difficulties. The second column then is how that translates to difficulty in the classroom. So not being able to focus on a lecture or their homework. And then the potential strategy or accommodation to help with that problem. Providing shorter assignments, breaking down tasks into smaller segments or more discrete segments, lightening the workload, as an example.
So when I'm looking at these accommodations and I'm thinking from the perspective of perhaps a teacher, a counselor, that's a lot of considerations, and I think people might feel a little uncomfortable making that determination what would be the best accommodation. So what would you say, and I know Betty Sue would say a school nurse, and I think that's really important that a school nurse is going to have a good gauge on what would be appropriate accommodations for the student. What else would you say in helping the person who is sitting in front of the child trying to help them?
Yep.
What recommendations would you make into making those determinations?
Yep. Well, I think absolutely getting somebody on the healthcare side of things, whether it's a school nurse or the person's healthcare provider, to at least provide a starting point of a framework for what some of those things should look like, and then bringing that back to the classroom. Even simply just acknowledging the need to do something does a lot, I think, to get the kid on your side.
Well, I guess there's no perfect science, right? Trial
There's
and error.
certainly not a perfect science, and that's why I say being flexible, being adaptable, trial and error. But, the unfortunate thing that I see in our clinic is that too often, at least this is how the child or the parent is relating it to me, is that we gave them these list of accommodations and they're not doing anything about it. That's unfortunately what I hear a lot. Now, whether the truth may lie somewhere in the middle, but or even we talked these over with the counselor and we agreed that these things were appropriate, and they sent out a message to all the teachers, but teacher X is not being very accommodating or understanding of the situation. And so sometimes it's just one out of maybe 5 or 6 or 7 teachers that are really perpetuating the problem.
And that can make the difference for a student, right?
Yeah, absolutely.
If they have light sensitivity, or I'm just thinking if they're not making those accommodations, that can really impair their ability to heal.
And so I guess maybe what I would say, if you were the teacher in front of the kid, what is the issue you're seeing? Is it that they are just getting tired and more headachy and more symptomatic that way as the longer they sit in the classroom? Or is it maybe some behavioral issue you're seeing? And that should be then the starting point for, okay, how do we tackle that with some of the overarching concepts of pacing, maybe short rest breaks as opposed to just completely shutting it down, things
Well,
like
maybe
that.
a list of accommodations, our administrators and counselors and so
Yeah.
on could provide those to the teachers so that when they have the student in the classroom,
Yeah,
they
absolutely.
can see some options.
Even simply having a table like this to
Yeah.
kind of just refer to
Yeah.
is totally reasonable to do. So, your influence, I feel, can greatly help or hinder a child's recovery from a concussion. Would encourage you to work with the student and their parent guardian. Try to be on the same team with them rather than having it feel like an adversarial type of relationship. Remember to try to be flexible and adaptable with your plans. And that the best plan that we might put on paper coming out of my office doesn't necessarily do any good if it's not implemented in the classroom. So that is my information or my presentation. I would be curious to hear from some of the folks out there listening. Perhaps what one lesson or idea will you take away from this talk? And you're welcome to put them up there or through the YouTube chat, maybe throw out any questions. I'm happy to.
So Kathleen is saying that she's used the handout from the CDC with her teachers. So maybe that's something that we can you provide me with that link, Kathleen?
Yeah, the CDC certainly has a lot of materials related to concussion in kids and supporting the classroom environment. So yeah, if you're looking for a place to turn towards resources, that certainly could be one. I believe you all, through the Department of Education, have also some links to resources.
Mm-hmm. Yes, I do have some on the website. I know that Betty Sue has, I've provided some links to, what would you call, I have a specific section under 504 for concussions, and I've linked what Betty Sue sent me, and then under special education, they also have some links to things and some information for TBIs, and so I've
There's
also
quite a
put
few
in-
resources on the special education page under TBI.
Yes, so there's a lot of resources on our site, and certainly I can send out anything that is shared with me out to the listserv, and if you haven't joined the listserv, that would be a good idea. And then I have had questions if you would be willing to share the PowerPoint slides.
Sure.
Great.
Or even some of the articles or
Yep.
tables. I don't.
Just something
Don't
handy
know if
that
there's
they
any
could.
copyright issues there, but anyways, we can figure something out what's appropriate to share.
Okay, perfect. Any other questions out there?
I think these are good take-home ideas. I appreciate your participating with the polls. Makes it a little more interesting from my end, at least.
Kathleen says, thank you. And for those of you who are the 504 list subscribers, this is the first of a mini-series. The next webinar that we're working on are 504 students or students with anxiety. So that will be coming up, and we appreciate so much that you provided this information. I know in my experience there is a high need. And we want to help the students. You know, we know that there's some depression and, you know, they really struggle because they want to play, and we want, you know, to get them healthy. And so how do we balance that out with helping them to feel happy,
Yeah.
but heal, you know, at the
Right.
same time. So.
Right. Yeah.
Lots of thank yous coming through.
Okay. Good.
So thank you so much. And thank you for joining us today. Have a great afternoon.